review of the hospital 340B reporting guidance by Kate O'Neill. And we have Northwestern Medical Center's fiscal year 26 budget adjustment request and a potential vote noticed. We're going to flip the order today, though. We're going to have Northwestern's presentation by Matt Sutter go first, and then we'll turn to Ms. O'Neill for the 340B. So with that, I'll turn it to Mr. Sutter.
Thank you, Chair Bossy. Let me get these slides up. All right, so we're going to review the Northwestern Medical Center's application for an FY26 budget adjustment. I'll start with a summary of their request. So they submitted a mid-year budget request that includes additional net patient revenue, other operating revenue, and operating expenses. If you see the table on the right, their proposal increases their NPR by just over $5 million, other operating revenue by $2.36 million, which in total is additional almost $7.4 million in operating revenue. They also have some additional operating expenses, which we'll review, but in net, adding an additional $2.5 million to their budget. In aggregate, though, or net, this nets out to an improvement of $5 million to their bottom line, or a difference of operating margin from negative 5.7% as approved to negative 2.1% as proposed. So as I said, while we review the other operating revenue and operating expense items, the relevant decisions before the board relate to their NPR requests. And this is because hospital budget orders explicitly cap NPR and commercial NPR and are the elements that we would need to amend in their budget. Links to their NMC's submission materials are available if you follow the links on the bottom right. So as part of this, there are some components here to the NPR increase. I'll go through each of these individually and discuss our staff recommendations. So during the hospital budget review process this summer, Northwestern was recognized by the board as a low-price hospital and were encouraged to market their services to compete with high-priced hospitals in their proximity. They've submitted additional NPR requests associated with these increased volumes and have provided the breakdown.
I'm happy to help out with recap what it.
Have provided a breakdown of the additional gross revenue deductions and net revenue by area here. And the submitted increases are largely based on the current run rate for these services. A more detailed explanation of each service change is available in their submission materials. As far as the staff recommendation goes, in principle, generally, staff would not recommend increasing a hospital's NPR cap due exclusively to unbudgeted volume increases. I think there's an exceptional case here, though, because the volume increases discussed were encouraged and intended to save the system money by driving care from higher price institutions. So staff recommends increasing the NPR cap by the amount identified here, but there's an additional expectation that NMC provide an analysis of the impact at the time they submit their FY27 budget. As part of their submission, additional NPR, there's additional NPR due to an updated estimate of the impact of Act 55. This was favorable, very favorable to their finances. They told us during their hospital review process that they would be updating and submitting an updated estimate here. And it nets out, though, to a $1.4 million improvement to their bottom line, effectuated by reducing budgeted deductions. And staff does recommend approval of that piece. In addition to this, they also submitted a request for a 3% rate increase applied across the board, across their charge master. Over 9 months, this request would result in additional $7.6 million in gross charges and net out to an additional $2 million. Breakout by inpatient, outpatient professionals provided there. Staff is not recommending approval of their requested 3% mid-year rate increase. However, I do want to note that Northwestern there's strong evidence that they're a low-price hospital relative to others in our system, which I think should be factored into our analysis of rate changes in the upcoming budget submissions. So broken out line by line, each line item in their submission. I can just start from the top. The marketing efforts, like you said, are $1.6 million. Staff's recommending approval of that. $1.4 million additional NPR for the updated Act 55 impact analysis. We are not recommending the additional $2 million of NPR from a rate increase. Quickly, we can go through the other operating revenue items here because I think they're important to understand the overall financial picture at the hospital. They have a $2 million budgeted for a Vermont Provider Stabilization Grant, $364 for the sale of a fixed asset to their local FQHC. And then on the operating expense side, they did have some unanticipated expenses, right? So they had a mobile sterilization unit, which is a significant, almost $2.8 million expense, some portable equipment rental for nuclear medicine, and then the $200,000 of expenses associated with the increased marketing efforts are included there. They're also to kind of offset some of these expense increases. They are reducing 4 vacant non-direct patient care positions at the hospital, the associated benefits for those FDA changes, and they have some reduced locum expenses there that are favorable to their budget. So staff recommendation would require modification to the NPR and commercial NPR cap in NMC's budget as follows: $2.46 million in additional, or $2.47 million in additional commercial NPR, and additional $3.03 million in total NPR. And then a breakout on the left table there, you can see the Act 55 update, entirely commercial, marketing volume, mostly commercial, 1 million out of 1.6. And then at the bottom, I did want to highlight, so what's really before the board today is an NPR increase. And I just wanted to provide context of that against their initial budget submission. So their approved budget baked in a negative 2.8% NPR decrease relative to their FY25 approved budget. As proposed, they're increasing their NPR by just over $5 million would make the year-over-year NPR increase relative to their 25 budget at just under 1%. So still well under the benchmark that we had established. And then as recommended by the staff, again, removing that increased rate from the ask keeps it to negative 0.6%, which is well below, considered against the 25 benchmark or 26 benchmark, well below it. So we do have some draft motion language here to approve in part NMC's application for mid-year adjustment. Like I said at the outset, the only modification necessary to their budget orders relate to the commercial NPR and total NPR piece. But we need the other items to have a full picture of their financial situation at the hospital. So happy to turn it back to you, Chair Foster, for any questions.
Thank you. Just one clarification question. In the draft motion language, the penultimate sentence says, NMC shall submit an impact analysis of its new marketing efforts on NMC volumes and system-wide NPR. When you say system-wide NPR there, do you mean NMC's NPR or the state of Vermont hospital system NPR?
I think what we're after is an estimated impact of the impact to the system of moving care from other providers to NMC. So understanding that this is a challenging analysis to perform, and would probably have some nuance and caveats in how it's performed, but really looking for an analysis of how successful were these marketing efforts really in driving care from higher price institutions to St. Albans.
Great, and that's what I had thought, and that is a tricky thing to measure, but really, really important. We shouldn't be giving additional revenue if it's actually not coming from somewhere else. The intent of this is to have these services performed high quality, hopefully quicker access and lower price. So if it's not going down somewhere else, or if it's not impacting somewhere else, I don't know if we've achieved what we would want to with this potential motion. But I support the motion. I'll go ahead and read it, see if there's a second, and then we can take board discussion and then public comment. So I move to approve a mid-year adjustment to NMC's fiscal year 26 budget by increasing its total NPR cap to $133,919,093, an increase of $3,031,618 from its established budget, and by increasing its commercial NPR cap to $86,170,103, an increase of $2,469,852 from its established budget. NMC shall be subject to all other conditions in its fiscal year 26 budget order, including the commercial reimbursement rate growth cap of 2.65%, Additionally, NMC shall submit an impact analysis of its new marketing efforts on NMC volumes and system-wide NPR. This analysis shall be submitted with NMC's fiscal year 27 budget in a form and manner prescribed by the Director of Health Systems Finances.
Second.
Thank you, Member Holmes. And I'll open up to board members for discussion, deliberation, and any comments or questions. Member Teachout.
Thank you. I support this motion, and I think the one thing I want to say publicly is that we hope this is shifting care to lower cost sites and not increasing utilization unless it's expanded access.
Thank you.
I support this motion, and thank you, Matt and team, for the analysis.
I support the motion too, and I just want to echo the concerns or the need for the impact analysis to ensure that this is actually lowering the total cost of care for the system by moving care from higher priced centers to NMC, which we know is a low price center. So that impact analysis will be critical going forward, so we understand this adjustment. But I support it.
I too support the motion. I would add that I would be comfortable with the charge master increase. I think I don't think I would have support for that given other people's comments, but I think Northwest Medical Center has, from all pricing data that I have seen, has probably the lowest prices of a hospital in Vermont. The other two that are low are critical access hospitals, which get cost-based reimbursement for Medicare. So they're in a uniquely disadvantaged stance and with regards to pricing among hospitals in Vermont. Understanding the limitations of the mid-year budget adjustment process, I think it's a little bit complicated, but I would support an increase in the charge master. And I think that probably will most likely be revisiting this in guidance and their budget submission for next year.
Great. I'll turn to the healthcare advocate.
Hi, Chair Foster. This is Charles Becker here on behalf of the healthcare advocate today. So our initial reaction was to encourage the board to not approve the application for failing to meet the statutory standard. 9456 requires a showing of need upon exceptional or unforeseen circumstances. We struggle to see that here. Certainly the application wasn't presented in those terms, but upon further consideration and in light of the budget order language, which exceptional in and of itself almost seems to encourage NMC to seek a mid-year adjustment, in light of the ongoing pressures on commercial payers, we think the staff recommendation is a good approach. Allow the NPR growth, but disallow the commercial charge increase. And with that, so I would say the HCA would encourage the board to approve the staff recommendation.
Great, thank you. And I agree. There's nothing unforeseen or unexceptional here that justifies a rate increase. I would agree with that component of it as well. And I'll open it to public comment. Mr. Billings, how are you? And welcome.
I'm well, thank you. I'm Jonathan Billings. I'm the interim CEO at Northwestern Medical Center, but not new to NMC, have been on the hospital leadership team for 36 years, so the subject is familiar to me. I appreciate the recognition that NMC is Vermont's lowest or one of the lowest cost hospitals in the state, and would reiterate that the 3% increase that we've requested does not change that status by our math. We would continue to be the lowest cost hospital in the state. We would just be that much closer to getting back to sustainability. NMC has been working hard at sustainability. We have used our cash reserves and have drawn those down significantly. A lack of this mid-year rate increase puts a bond covenant in peril for the third time. Having to pay off the bank or other draconian matters would precipitously draw down days cash on hand. And we are concerned about our burn rate of that and concerned about our ability to maintain key services in northwestern Vermont that I believe the Green Mountain Care Board and the Agency of Human Services want maintained in northwestern Vermont. 98% or more, or approximately, of our outmigration goes directly to Vermont's tertiary care center. We lose very little inpatient care to other hospitals other than Burlington. And so the analysis, we won't be making up new patients. It will either be expanded access in our community for affordable care, or it will be patients seeking care at more expensive facilities coming back to us. So I think we're confident there. We recently earned Vermont's highest ranking in quality from Leapfrog. And so you have a high quality hospital at lowest cost who is asking to be helped to be sustainable. And that's the reason for the mid-year increase. And so we appreciate the work that's gone into this and the analysis. And we would encourage you to grant the request as presented.
Thank you for your comments, Mr. Billings. Two quick questions. What is unforeseen or exceptional that justifies the rate increase request?
I think the unforeseen is hard. We've seen this for a while. We've spoken to you folks a number of years in a row around NMC's financial situation. I believe we've lost money from operations for 7 of the past 8 years. If you go back to that, it ties to a significant rate reduction that has never been caught up. And so I don't know if unforeseen is the right word, but so I don't have a good answer for you on that, because that's not how we score it as we attempt to keep services open and provide care for our community.
Understood. That's the legal standard, so that's what we have to apply.
Yep.
I appreciate all your points fully. 2 other quick little follow-ups. One, did you ask Medicaid for an increase?
You want me to chime in,
Stephanie
Jonathan?
Bro, our Chief Financial Officer, is on. And I was not aware of Medicaid ever giving increases, but I am not your Chief Financial Officer, so I will defer to Steph.
Well, I guess here's my point on the question, really, which is, I appreciate, and we all do very much, the good work that you're all doing on quality and your efforts on quality and keeping your prices affordable for your community. But any rate increase does impact a financially vulnerable insurer and add to our extremely high commercial insurance costs. So from my perspective, I don't know that the commercial market is the place to go for increasing costs. It's also really a bit of an inequitable way to increase revenue for a hospital when you really have a statewide tax-based system that's not regressive. So when we have these budgets, it often comes like, hey, let's get more from commercial. I guess I'm flummoxed as to why.
Yeah, I can add I appreciate that. I agree with you. And I can add that, we have specifically asked for an increase in Medicaid reimbursement, not for all charges on our charge master, but in an area where we are particularly struggling to cover the cost in that program. And obviously they're not able to accommodate that. They're not able to do so. But yeah, we've had those conversations directly. We've asked.
Okay, thank you. I appreciate you asking. And it's sort of this bigger problem we have statewide where there's no more money. And it is really difficult. Last question, and I appreciate the comment. I didn't actually pick up on this before, but the bond covenant risk, can you explain that to me? Because as I look at it, Northwestern has, I think, the highest reserves in the state on a days cash on hand basis.
Yeah, happy to. We have three bond covenants. One of them is days cash on hand. We're not concerned about tripping that bond covenant. Another one is our just overall debt to capitalization. How much debt do we have? And that one we're not in danger of tripping either. The third is a debt service coverage ratio. And so that's really a measure of how much income are you generating from operations, and does that income allow you to pay off, your debt payments and your debt obligations in the coming year? And so we're not generating any positive operating income. It's negative. So we're not able to meet that covenant. So that is the one that, we will likely trip for a third time. And I've had conversations, kind of proactive conversations with the bank, but we don't have a good answer from them or response as to what they're going to do when we ultimately, default on that for the third time.
I see. So they're disjunctive, each of those three triggers.
Yes.
All right. I might ask you offline about that a little bit more at some other juncture. It's not relevant to this, but I would like to understand that a little bit more. Okay. Thank you. Any other public comment?
No, I have to pee. And I
Okay. Hey, Abby, I think you're unmuted. Hey, Abby. Yeah. I'll take a vote. All in favor of the motion, please say aye.
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 Aye. The motion carries 5-0. Thank you very much, Stephanie and Jonathan, for coming and for presenting this to the board.
Thank you.
Thank you.
Thank you, folks.
Thank you. And thank you, Mr. Sutter, and your team as well. I'll turn to Ms. O'Neill for the 340B guidance.
Good afternoon, everyone. I will share my screen. If there are any issues with seeing that. Good afternoon. I am Kate O'Neill, and I'm the Director of Prescription Drug Pricing here at the Green Mountain Care Board. And I'm presenting today along with our policy analyst, Michelle Loengus-Lozano. And we're presenting to you on the Vermont Hospital 340B reporting guidance. And this is for new hospital reporting. It's a requirement that comes out of Act 55. So Act 55 establishes this new requirement that each 340B participating Vermont hospital must now report to the GMCB annually by January 31st on that hospital's participation in the federal 340B pricing program, drug pricing program. And it's done in a form and manner that is prescribed by the board. Hospitals need to report on acquisition costs for drugs purchased under the program, payments that hospitals received for those drugs dispensed and administered, payments made to contract pharmacies and other outside vendors, as well as a narrative description of the ways in which the hospital uses revenue from the program and a list of vendors that they work with under this program. So this new requirement began with the enactment of Act 55 on October 20th. We published draft guidance and started a public comment period that ran through November 19th. And today we're here to present the final draft guidance to you. We did intend to recommend a vote, and we have recommended motion language at the end of this presentation. It occurs to me, though, in last minute looking at the agenda, that I don't think that a vote was noticed. So we'll continue to go through the slides here and present the draft guidance to you, and then you'll let me know if we need to come back for a vote. So what I want to say now, though, is that we did make changes to the draft guidance. It's now in a final form to present to you. And it is, we believe, responsive to the many comments that we received, which we'll go through now. Just as a reminder, the deadline for hospitals to submit data and narrative reporting is January 31st. But because the process we established here incorporates data collection through the adaptive data portal, it will take additional time for board staff to publish the individual reports and a compiled dashboard of hospital submissions, but that it is our intent to do. This final guidance for review that we're presenting to you today is available on the Green Mountain Care Board website under the board materials for this meeting. So this guidance includes the data submission requirements, the uniform reporting requirements, submission deadlines, and information on requesting extensions and requests for confidentiality. We did receive public comment from VAS, UVM Health, Northwestern Medical Center, and Rutland Regional Medical Center. So here we'll share a description of those comments and the themes and our responses, which largely are reflected in the guidance, and changes were made where appropriate. So there were comments and concerns about the reference in statute to both fiscal and calendar year, and it made it confusing as to what is expected to be reported. So we adjusted the guidance to reflect that data submission is to be based on the hospital fiscal year, and we think that this ensures consistency across reporting requirements. There were concerns raised about separate reporting for prescription drugs that are bundled as well as paid separately. Because statute requires reporting of payments made in bundled payments, and it specifies the methodology for estimating those payments, hospitals must use the tools they have to make these estimates. We do want to recognize, though, that these new reporting requirements may necessitate working with the hospital's data vendors to modify methodology and to add new fields in order to comply with state statute and Green Mountain Care Board reporting requirements. So I just want to note here that if needed, a hospital may request an extension to the submission deadline, and the guidance provides instructions on how to do so. Also related to the concern around bundled payments, there was a request for consideration of the estimation methodology or allowing reporting of $0 for bundled payment reimbursement. Again, statute requires hospitals to estimate drug level payment amounts by comparing actual acquisition costs to wholesale acquisition costs when administered drugs are included in a bundled payment. It's our determination that the board isn't authorized to modify this statutory methodology or to permit hospitals to report a value of $0 in lieu of the estimate. A question was asked about reporting average wholesale price instead of wholesale acquisition cost. In the guidance, we clarify that no, hospitals may not submit AWP for payment amounts or for wholesale acquisition cost or WAC-based estimates. Statute requires reporting of actual payment amounts for separately paid drugs and the use of WAC or wholesale acquisition costs for estimating bundled payments. There was a concern in the draft guidance that we included reporting to be disaggregated by major payer. We did update the guidance, so now the guidance that you are reviewing today is updated to only require reporting for reporting aggregated across payers. We did, though, include an option for hospitals to voluntarily report for each major payer separately. We think that's very valuable information to capture, but it's voluntary. Hospitals will see that this voluntary reporting option is reflected in the adaptive reporting portal. There was a request to define 340B program revenue. So in Act 55, it says hospitals are to report on a description of the ways in which the hospital uses revenue from its participation in the 340B program to benefit its community through programs and services funded in whole or in part by revenue from the 340B program. And we determined that this is referring to the net income that a hospital retains from its 340B program. So meaning it's the payments received for the 340B drugs minus acquisition costs, contract pharmacy fees, and other vendor expenses. And this is reflected in the guidance. And for the next set of comments, I'm going to turn it over to Michelle. Michelle, take it away.
Yes, thank you, Kate, and hi, everyone. So this question here relates to hospitals that participate in Medicaid as a 340B carbon, meaning that hospitals use 340B drugs for Medicaid patients, and then they reconcile those claims with the state to avoid duplicate discounts. During public comment, hospitals asked how those reconciliation or offset payments should be treated in the reporting. So now the guidance and the adaptive portal have been updated to require hospitals to report those Medicaid carbon payments separately. Next, commentators noted that the draft guidance initially required separate reporting of calculated 340B income and margin, which is not explicitly required under statute. After reviewing that feedback, we have agreed to remove those values from the reporting requirements in the guidance. Hospitals that are not subject to the federal group purchasing organization prohibition raised a concern that they do not maintain wholesale acquisition cost or WAC accounts and therefore may not have ready access to WAC pricing. The statute is clear that for administered drugs paid through bundle payments, as Kate has mentioned earlier, hospitals must estimate payment amounts using a comparison to WAC. Unfortunately, this is just a statutory requirement that cannot be modified by the board. Sorry, just to go back to that slide. However, for drugs that are paid separately, the guidance has been updated so that it allows hospitals that are not subject to the GPO prohibition to report GPO pricing where the WAC is not available. Again, this is just for drugs that are paid separately, not bundled. To support this, the adaptive portal includes an additional column for GPO price reporting. Next, this was a comment raised that is very fair. There are no administered drugs in the in-house or contract pharmacy setting. So we have adjusted guidance language to clarify this by rewording the reporting requirements within each distribution channel. And you can find those in the slide above. They're now in 4 different distribution channels. Next, commentators raise the concern that calculated margin alone does not fully reflect 340B net revenue if associated expenses are not included. In response, the guidance clarifies that hospitals should factor in payments to vendors, contract pharmacy fees, and other administrative expenses when determining overall program net revenue and margin. The adaptive portal has also been updated to include a reporting field for those associated costs, as it will reflect more of a true value. Then one of our comments noted that while federal law does not require manufacturers to extend 340B pricing to orphan drugs, some manufacturers do extend these prices voluntarily. So to ensure complete reporting, the guidance clarifies that orphan drugs should be included when a manufacturer voluntarily extends 340B pricing for those products, and there is a reporting field now available on the adaptive portal for this as well. Next, some hospitals expressed concern that the required description of how 340B revenue is used for community health initiatives included elements that are not explicitly listed in the statute, such as investment amounts or service descriptions. After review, we did conclude that the statute establishes minimum reporting requirements and allows the board to require additional information. We believe that the additional detail requested in the guidance is intended to provide a clear understanding of how 340B revenue supports community access to care, hospital-based programs, and is directly related to the objective of the 340B report. Finally, those were all our public comments. And as Kate mentioned before, we do just want to reiterate that we recognize that these new reporting requirements may require hospitals to work with their data vendors to update systems or methodologies. So the guidance does include a formal extension request process where any request must include a proposed timeline and a detailed rationale. We strongly believe that through this approach, we balance statutory compliance with flexibility for hospitals. Now I'll pass it back to Kate for her concluding remarks.
Sorry about that. Basically, we just want to say that we appreciate all of the many comments that we received, and we think that those comments improve the guidance, and we hope that the affected submitting hospitals find these changes to meet their needs. We're available to continue to address questions as they come up during the reporting period. Our contact information is here. And the last thing that we have for you is draft motion language. I don't know if we're able to do that today. However, you let me know.
So we can, Kate, why don't you pull up the draft motion language? I'm not sure if the members are all ready, but I'll make the motion and then we can discuss. So I move to approve the draft Vermont Hospital 340B reporting guidance as presented today, December 17th, 2025.
I'll second.
Great. And I'll open up to board member deliberation, comment, or any questions for the staff.
This is Sarah. I'll jump in. Is that okay? I strongly support the work that you've done to get some more transparency around the 340B program, and I encourage hospitals to submit voluntarily where they can. Thank you.
Yeah, this is Tom. Thank you, Kate and team, for pulling this together and helping us out today. Especially appreciated your careful walking us through the the measurement challenges, including those around the wholesale acquisition cost. So I think it's appropriate that the first year of this, we are seeking uniform reporting, voluntary participation, hopefully all hospitals, as Member Teachout said. I think it's a good start toward building greater transparency. I also really appreciate the community benefit reporting requirement. That too, I think, goes a long way to what we're trying to accomplish. So thank you.
I support it, and I just want to say thank you, to Kate and your team there. I feel like this is a really robust process, and we got lots of comments that were really, really helpful and improved the, eventual, guidance here. And I so appreciate when we get those comments. It does improve what we do, and just want to thank you, and I do support it. The transparency will be helpful.
Just want to echo my board member colleagues' comments, and just great appreciation for the work. And I think you've digested this quite well, so I appreciate it. Thank you.
I'll turn to the HCA.
Hi, Chair Foster again, Charles Becker for the HCA. On behalf of the HCA, I just want to express appreciation to Kate and Michelle for transforming the statutory language into a clean and actionable guidance document. As someone who was involved in the legislative committee discussions about the 340B reporting, I thought the original draft guidance was good. I think it did what was intended and would have produced the reporting that was consistent with the legislative mandate. But I think this revised guidance document is even better. So, the HCA wishes to express appreciation as well to the hospitals that commented. This was definitely one of those instances where constructive feedback made the final product better. As maybe has been alluded to here today, this 340B reporting is a time-limited project. I think the reporting sunsets in 5 years, and I think this guidance sets that 5-year period off on really solid footing. So again, appreciation to Kate and Michelle, and on behalf of the HCA, we would urge the board to approve the revised guidance.
Thank you very much. Any public comment via raise the hand? Patrick Rooney.
Thank you, Chair Foster. Patrick Rooney, the Vaz. By now it's been said, but Kate, we really appreciate the opportunity to provide feedback We also agree that through this process, the nuances that were discovered and the intricacies around 340B allowed us to shed more light on a more accurate reporting process. That said, as we operationalize this legislation, to Mr. Becker and Jess's comments, there probably will be more that comes. And so our intent is to keep those lines of communication open with you, because we do want this to be accurate and robust and informative, because it is time limited. So we appreciate the work that you and Michelle did, and we'll be in touch as matters come to the surface, whether member-led or VOZ-led, but we really appreciate the opportunity to make comments. So thank you very much.
All right, thank you. And thank you, Voss, for your assistance and participation. Mr. Carpenter, Walter, you get mad when I call you Mr. Carpenter.
No, just call me Walter, Owen. I've got a season's pass to the board.
Lucky you.
Yeah, hey, every year since it started, renews. I just want to say thanks to Kate for getting so much that's so complicated into such an easy and understandable space.
Thank you, Walter. Appreciate you saying that. And I don't know if anyone recognized it, but I think today was Miss Lozano's first board presentation. Am I correct on that?
That is correct.
All right. Michelle, thank you so much. You did such an outstanding job, and we're so glad that you're here. You're new enough that I don't feel like I can properly haze you just yet, so I may wait. I usually like to haze the new people, but thank you so much for being here and for your work on this.
Of course, it's been incredible working with Kate, and we really could not do it without the legal team or the finance team, who really helped us through with other public comments. So just thank you to everyone in general.
That's great. I like your snowy backdrop, even though I know you're not in Vermont. We'll show the governor's office this video. All right, all in favor of the motion, say aye.
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 Aye, and the motion carries.
Thank you,
All right,
everyone. And I will just say for next steps, we will take the guidance that it is draft until now. It's final, and we will post it on the website, and we will make sure that all the hospitals have access to it. And yes, for sure, the lines of communication remain open as you all operationalize this reporting. We're here to help and to learn alongside you.
Thank you very much, Kate. Any old or new business for the board? Okay, then I'll move to adjourn.
Second.
All in favor, say aye.
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 Aye. And we're adjourned. Have a nice afternoon.